Please open the commission.
The Royal Commission is now in session. Please be seated.
Yes, Ms Hill.
If the Commission pleases, I call Dr. Kate Fox.
I solemnly and sincerely declare and affirm that the evidence I shall give will be the truth, the whole truth, and nothing but the truth.
Please take a seat, Dr.
Please
Fox.
sit down and make yourself comfortable.
Thank you. Dr. Fox, could I ask you to state your full name, please?
Kate Suzanne Fox
And whereabouts do you live?
in Broome, Western Australia.
What do you do for work, Dr. Fox?
I'm a general practitioner.
Dr. Fox, you've prepared 2 statements for this Royal Commission.
I have
Operator, could you please display document ID WIT stop 1145 stop 0001 stop 0001. Dr. Fox, do you see a statement on that monitor before you dated 16 June?
I do.
And is that the first of the statements that you've prepared for the Royal Commission?
It is.
And are the contents of that statement true and correct?
Yes.
And are there any changes or amendments that you'd seek to make to that?
No.
Commissioners, I tender that statement.
Yes, well, I'll take them as 2 separate exhibits. The statement of Dr Kate Suzanne Fox, dated the 16th of June 2019, will be Exhibit 4-13, and her second statement bearing the same date will be Exhibit 4-14.
If that statement could be taken off the monitor, operator. Dr. Fox, you work at both Brahms and at an Aboriginal community, Bittajanga.
I do.
Could I ask you to describe your role at Brahms?
At Brahms, I work as a general practitioner. Brahms is a large Aboriginal community-controlled health organisation based in Broome, and it is comprised of, well, multiple people work there, most of which are Aboriginal people. There's Aboriginal health workers, Aboriginal health practitioners, most of the administration staff, and the driving staff, the account staff are all Aboriginal, and there's an Aboriginal board that governs Broome Regional Aboriginal Medical Service. And I also work with other GPs. It's a service that has multiple GP consultation rooms. It has a dental space and dental service, antenatal service, child health service as well. And I see patients there on a daily basis that come in on a sort of walk-in basis, so people are seen as they arrive.
And is that based in Broome, Dr. Fox?
That's in Broome.
Is there such a thing as a typical day at Brahms?
Yeah.
And are you able to describe that to the Commissioners, Dr. Fox?
Yep. So I arrive at Brahms. There's a morning meeting that all staff are expected to attend, whereby important announcements are made, or most importantly, there's a list of people that are required to be seen for review that day that are read out, and if we're having trouble locating people, then other people in the room might know where they will be or can help us out with trying to find them. And then after the meeting, everybody goes to their individual jobs, and the clinic will open and patients come through, and patients will generally come through and be seen first by an Aboriginal health worker or an Aboriginal health practitioner who perform depending on their capacity and their skill set, might just perform general observations on them, so vital observations, and then send them off to see a doctor, or may take a short history, may do an ECG or whatever they think is necessary, and then the patient will go back to wait in the waiting room, or if the GP is available, a GP will come and grab them, and I'll take them to my consult room and perform a consultation, and they leave, and the day goes like that.
Where do patients come from to attend at Brahms?
So largely Broome, they're Broome patients, but Broome is the biggest regional centre in the Kimberley, and there are a lot of services in Broome that aren't available outside of Broome. So lots of patients or people travel to Broome for those various reasons, and so Broome also services a lot of the remote communities, or even people that are visiting from Kununurra.
In your statement, you describe working at Bidajanga, which this commission has heard a bit about this week, for 2 days each week.
Mm-hmm.
How do you travel to Bidajanga?
I travel to Bidajanga on a small plane.
And could you describe the setting of the Bidajanga community to the commissioners? What's it like?
So it's one of the largest Aboriginal communities in WA, of a population of, the ABS stats will tell you, between 700 and 800, but population can swell to around 1,000 during busy periods. It's located about 200 kilometres south of Broome on only recently sealed roads the whole way. There's been a lot of advocacy that's gone into getting a sealed road to the community. It's close to the coast, and is a community that has multiple different services available to it, which I can
Certainly.
describe if you like. So there's a health clinic, which is where I work when I go down there. There's a police station. There's municipal support through a council, and other support such as Centrelink. There's a school that goes all the way up until year 12, which is amazing, and there's a home and community care service, which I know you guys have heard from some of the service providers at HAC. There's a women's arts centre in the community that has recently got up and running again, which is great. There's a kiddie link, which is also just started to happen, which is about providing care for children for a small period of time.
Is there such a thing as an average day at the health clinic at Bidajanga?
Yeah, there's an average day. It's definitely can be really different every day. But an average day for me would look, so I'd fly out of Broome at 8 o'clock and would arrive in the clinic by about 9 a.m. And usually the clinic is open by then, and there are patients already in clinic and that have already been seeing so rural area nurses. Bidajanga is a little bit different in terms of its clinic setup, so it's a lot smaller. It doesn't have as many resources or access to staff, but it's a smaller community. There are Aboriginal health practitioners, Aboriginal liaison officers, and Aboriginal administration staff members, and then there's also rural area nurses, who none of which are Aboriginal at the moment, and there's 2 senior GPs, myself and a full-time GP that's new to Bidajanga. She's newer than I am to Bidajanga, and they also there's also GP registrars so CAMS is supports GP registrar training. So there are GP registrars that come to work at Bidjadanga and other communities that are under the auspices of CAMS for 6 to 12 month blocks. So the average day when I get there will involve, it's a similar setup to Broome. So a rural area nurse or an Aboriginal health worker will see a patient first, and then I will see them after. And I guess it's different in that Bidjadanga doesn't have the same amount of access to services that Broome does. So we don't have quick access to pathology results or X-rays or CTs. So if somebody is requiring emergency care, then we're required to provide it, and it takes resources away from the clinic, and it's much more complex care than I provide in Bidjadanga. Yeah.
How long have you been working at the clinic at Bidjadanga?
So I've been on and off at the clinic in Bidjadanga for 2.5 years. Yeah.
Dr. Fox, you completed your medical studies and then residency in Perth?
Yep.
And you obtained your fellowship of general practice in 2018?
I did.
When did you move to Broome, Dr. Fox?
The beginning of 2017, so January 2017.
What motivates you to work in Broome and then more remotely in Bidjadanga?
So I'd like to preface that response by just saying that I'm very aware that I'm a junior GP and I'm relatively new to working in remote Aboriginal health, and that I'm aware that there is a lot of burnout in my line of work, and that what motivates me, well, I guess, my experiences, life experiences 5-10 years down the track may not be, will provide me with different motivations, and I'm not sure where I will be. But at the moment I am incredibly motivated to do what I do, and I think, put simply, it's about being able to contribute to something that I feel passionate about, and knowing that I can make a difference. And even if it's just on an individual level, I think that ideally there's a bigger picture difference, but I think that day-to-day difference that I can make in people's lives, that motivates me. And I think my interest in Aboriginal health is a product of my life experiences as well, which starts from growing up in the country and being a country kid and having a passion for rural areas and rural health, and then being lucky enough during my medical degree to have amazing exposures to Aboriginal community-controlled health organisations, both in remote and rural settings, and witness firsthand the inequities that are associated with Aboriginal health outcomes. And then was lucky enough again to get a job at CAMS, which is an amazing provider of Aboriginal medical services, and had some amazing female GP mentors when I arrived at CAMS and started working in Bidjadanga that were of the same mindset as me and believed in the same way of practicing Aboriginal healthcare, and I'm motivated to be able to continue that. I think in terms of Broome, Broome's a pretty lovely place to live and to work. I don't think there's much that's required to motivate here. If you're interested in any kind of the natural wonders that Australia has to offer, Broome's a beautiful place to live and work. And my husband has a supportive partner, has a good job in Broome as well, so that helps in terms of motivation. And just going back quickly to Bidjadanga community, so working remotely, the community itself is a really lovely community that are incredibly caring and considered and welcoming and forgiving of people that make mistakes. So I think there's a lot to motivate me.
Could you describe the physical location of the clinic at Bidjadanga, Dr. Fox?
So it's located in, I would say, essentially in the middle of Bidjadanga community. Yeah.
How do people access the clinic?
So most people in Bidjadanga don't have access to their own transport, and they're required to walk to clinic if they're able. Clinic has access to vehicles to be able to pick people up if they require care. And every morning there will be a health worker and a rural area nurse whose job it is to look at the recalls of people that we want to see and go out and find people to bring them into community.
How do older residents at Bidjadanga who may be frail attend upon the clinic?
So that's obviously a next level of difficulty with access, because it always is going to rely on somebody to be able to transport them to clinic, and we often have difficulties with older, morbidly obese, or even just frail patients who sometimes can't access the vehicles that are available to CAMS are not always easily accessible. They're usually four-wheel drives. The clinic bus has multiple steps to get up into it, so it can be really tricky to get older patients into clinic. And sometimes, I know that HAC sometimes have access to a car that they can use, which is lower, and we try to use that if we can. But also, if we have the capacity, GPs and nurses can go out and do home visits as well.
In your statement, and you've referred in evidence today to the complex care requirements of the older residents at Bidjadanga, what are those complex care needs, Dr. Fox?
Bidjadanga has a significant amount of complex, really poorly controlled, but also difficult to control despite optimum management, chronic medical conditions. For example, people suffer from type 2 diabetes, mellitus, and all of the awful complications that come along with type 2 diabetes mellitus, which nephropathy or damage to their kidneys, retinopathy or damage to their eyes, which can lead to blindness, damage to the blood vessels of their heart and brain, leading to stroke and heart attack, damage to the blood vessels and nerves of their feet, which lead to chronic ulcers that can progress to needing amputations of legs, foot, limbs, and so diabetes is its whole world in itself, which we are very much aware of, but that's only one of the conditions the complex conditions that people in Bidjadanga suffer from. Other ones would be chronic kidney disease, which is highly prevalent in Bidjadanga and which progresses on to, in a lot of cases, not a lot, but some cases, to end-stage renal disease requiring dialysis, which brings into play things about being able to have dialysis on country, or have dialysis to have to go off country to Broome to be able to have dialysis, because it's 3 times a week that people, at least 3 times a week, they would need it. Other complex chronic disease requirements are respiratory conditions like chronic obstructive pulmonary disease, bronchiectasis, asthma. People suffer from heart disease, heart attacks, strokes, the usual chronic medical conditions like osteoarthritis and hypertension, and high blood pressure and high lipids or dyslipidemia. But with older people, those conditions are much more prevalent and usually much more difficult to control. And obviously the usual complexities that come with being older are also suffered by people in Bidjadanga. So just having frailty or mobility issues or incontinence issues all factor into the complexities, and other care needs like needing to care needs for environmental health or, social and emotional well-being, health and mental health, all have make the complexities, outstanding in Bidjadanga.
In your statement, you describe older Aboriginal people as presenting with recurrent, complex acute needs. What does that mean for your ability to care for older residents at Bidjadanga, Dr. Fox?
So by acute, I mean conditions that where a patient experiences symptoms of an illness or an injury that has happened in the last days to weeks to months, and they present to clinic with those conditions, which could be having symptoms like coughs, colds, skin infections, or other illnesses that are considered acute on chronic medical conditions, like an acute exacerbation of their COPD or an acute kidney injury on top of a chronic underlying kidney injury. And people present to clinic with these acute needs that are complex as well, and being able to and people present to deal with their acute needs because they have symptoms from them, and most of the chronic conditions that are complex and people don't have symptoms until it's way too far down the disease process. So that's the reason behind, and then it's the underlying health literacy that prevents people from being able to come in and address their chronic needs. But if you have lots of people that are coming in for acute care needs, then it means it makes it incredibly difficult to be able to address underlying chronic care needs for older patients in Bidjadanga.
There are 5 languages at Bidjadanga, and we've heard evidence this week about language barriers that can persist when working with older Aboriginal people. In your statement, Dr. Fox, you describe language barriers as a crucial barrier to accessing care. How do you manage language barriers in your practice when you are working on country?
There's significant language barriers, and particularly in older people who sometimes speak limited or no English. It's a really tricky part of the job, and I think there are simple things that I use to try and break down those language barriers, such as even just learning some of the local languages, so the traditional owners' languages of Garrajari, learning some simple words that show that I'm respectful and know those words, and also can help the patient understand me, and for me to help understand what's happening for them. Other ways of doing it include, often, especially with older patients, we'll try and make sure that the home and community care team, so Faye or Ryan, who I know that you've heard from earlier this week, I will try and make sure that one of them can be present during the consult. But even if they don't know the specific language that a person speaks, they have this amazing relationship with the older members of community, and they are incredibly valuable in trying to break down some of those language barriers. So that's another way that I can work towards that. I also frequently use family members as interpreters, which is often because older family members come in with their older relatives, and they know them the best, and that is not ideal and has its own issues in terms of being able to culturally discuss issues in front of a family member. But I do that, and I just make sure that I'm aware of those underlying issues. I also will utilise the Aboriginal health worker or Aboriginal liaison officer that's in clinic as well at times, but again, that's about being careful not to overstep any cultural boundaries that might make it inappropriate to do so.
Do you use formal interpreters in your role?
I don't. I have to say that I've not ever used a formal interpreter for Aboriginal patients in Bidjadanga. I know that the service is available. I don't know. I can't comment on it because I've never used it, and I don't know that they would have all of the 5 different Bidjadanga language groups. But I think the main reason for not using official interpreters is purely because I spend a lot of my time in consults trying to build trust and rapport with a patient, and having a over the phone interpreting service I think would really break down that trust.
How do you build relationships of trust, Dr. Fox?
I think so. Trust is really, it's really important to build relationships of trust, and I think trust is important in any therapeutic doctor-patient relationship, but it's next level when it's a white doctor and an Aboriginal patient, and I think that's due to the impact of historical impacts of colonisation and past discriminatory government policies and marginalisation or essentially there was exclusion of Aboriginal people from white Western health services. So and those past discriminatory policies have engendered this transgenerational distrust in white people and white health services. So I'm fighting an uphill battle to build a relationship of trust, and trust is important so that I can build some rapport and engage a patient in care and to make sure that they can be engaged and can be empowered to improve their own health outcomes. Ways that I do it, I think, are about having an awareness of those underlying issues that can lead to those distrustful relationships, and it honestly takes a lot of time, and I think that's where continuity of care builds into it, because you need to have time with patients to build up that trust. And I'll often spend a lot of my time in consultations just getting to know a person, talking about things that I know about them, or talking about the footy or the Dockers, and doing that before I can, and often over multiple consults before I can even look at potentially addressing some of those complex chronic health needs.
How do you deliver culturally safe care in those set of circumstances, Dr. Fox?
Cultural safety is a whole topic of its own, and should always be defined by the people that are receiving the care. Providing culturally safe care from an individual perspective as a doctor, I think, is about being having an awareness of the underlying issues, cultural and social and emotional issues, historical issues that affect that person's relationship with you, and having an understanding that your agenda of what you believe to be best practice or best care for that person, which is based on your own background and your own beliefs and attitudes, is not always what the patient will perceive to be, the best management of care. And it's about accepting that, and for example, if a patient doesn't want to go to an appointment in Broome or to be evacuated from community because they have a sorry camp or a funeral that they need to be attending, it's about hopefully knowing that you have that trust in that they feel comfortable to tell you that, and then accepting that, and working with them to troubleshoot and to reappoint appointments, or to make sure they understand the risks of remaining in community, and setting good safety nets in terms of if it was somebody that needed to be acutely evacuated.
We've heard evidence this week that older residents of Bidjadanga want to stay on country. Is that consistent with your experience, Dr. Fox?
Yep.
In your experience, are older residents able to stay on country?
No, not for as long as they'd want to. No.
And why is that, Dr. Fox?
I think it's an interplay of all the things we've been talking about today. So complex chronic disease and the other barriers that come along with being an older Aboriginal patient living on country means that it's not always, it's not always possible to remain on country. And I think that is because there aren't the resources to be able to remain on country. I think and ideally, I think that's, it's why there's a Royal Commission into aged care. I think it'd be amazing to have some better resources for bigger communities like Bidjadanga, so that older people can stay on country, because there is a deep Aboriginal people in Bidjadanga have a deep connection with family and with country, and there's evidence to show that people do better, staying on country for as long as they can.
What employment strategies would assist people living remotely, such as at Bidjadanga, to stay on country as they age?
So I think there's a few that we've alluded to, but I think if the biggest thing I would say would have to be having access to a home and community care service that has the capacity to be able to provide good quality, effective care. And I think that's about having, so in terms of employment strategies, it's about having enough suitably trained staff, ideally Aboriginal staff ideally locally trained Aboriginal staff members. But I want to impress the importance of suitably trained. I also think there needs to be employment strategies to try and improve not only staff members that have aged care, culturally safe aged care training in home and community care services like Bidjadanga, but also I think Bidjadanga in particular would benefit from having a home and community care services that has access to at least one clinical nurse specialist that's trained in aged care, and ideally has renal training as well. And I think the benefits that a trained nurse can bring to a home and aged care services are help with things like medications, with recognising when people are unwell or might have signs of cognitive impairment or dementia, and helping get them into clinic for review, and also being able to start that process of helping people understand more and improving health literacy levels about the importance of preventative healthcare and chronic disease management, because it's ultimately those chronic diseases and the everything that comes with it that prevents people from being able to remain on country. And in terms of a renal trained nurse, as mentioned before, the Bidjadanga has a huge amount of chronic kidney disease that progresses on to end-stage renal failure, and at the moment most people have to leave country to go to get haemodialysis. We do have the capacity at Bidjadanga to have a home haemodialysis centre, and we do have one older member of community that sites on home haemodialysis in Bidjadanga at the moment, and she has her daughter is her carer, which is an incredibly difficult care job to do. She's required to work the machines and put her mother on home haemodialysis 3 times a week, as well as trying to work a full-time job, and they have no on-the-ground support from a renally trained specialist. It's all phone advice from a company that works in Perth. So I think that would be having a Aboriginally trained nurse would go a long way towards improving older people's ability to remain on country.
Do you see many carers in your role at Bidjadanga?
Yeah, I see carers, yeah.
What observations do you make of the carers that you see?
The carers that I see are incredible, and I think they are often not only caring for one really unwell patient or family member, they have multiple different people in their lives that they're caring for, and just take it as the norm. And often I see a lot of carer fatigue where the carers themselves don't really even recognise how they're being burnt out and aren't able to look after themselves, and it's hard. It's really hard, and I spend a lot of my time advocating for carers and trying to help look after them and giving them access to online carer support numbers and things like that.
What support is available to carers on country, Dr. Fox?
So there's on country the only there's no specific carer support, but there is, except the clinic and the home and community care service. But the home and community care service also provide respite for the carers, in that carers can so the person being cared for can go to the home and community care centre in the morning, and that provides a bit of respite for the carer. But other than that, there's nothing else on country.
Do carers have access to respite beyond Bidjadanga, in your experience?
There's respite for the person requiring care. The only place is Germanus Kent, which is in Broome, but it's often really difficult. I have heard stories about potentially sending people to Derby and especially for the home haemodialysis patient, sometimes that respite needs to come from Perth, which sounds ridiculous. But it's often really difficult to get access to that respite care at Germanus Kent because it's full, and there's not a lot of other avenues.
Dr. Fox, what could improve the quality of care for older residents at Bidjadanga?
I think there's a lot of things that can improve the quality of care for older people at Bidjadanga, and I think my statement outlines a lot of things, and I think there needs to be a broader government priorities on addressing and preventing Aboriginal people from becoming sick in the first place. But I think in terms of specifically in Bidjadanga, the most useful thing would be improving that home and community care service that we've just talked about. And I also think the other important thing is being able to ensure that services that are providing care can access continuity of care and be able to have continuity of care, because that's a really important part of having quality aged care for Aboriginal people. And I know there's a lot of turnover from clinic staff in Bidjadanga. In fact, I'm one of the longest standing, and I've been there for 2.5 years. So I think if you can improve continuity of care, which is, I know, across the board in remote Australia, so it's not an easy topic to tackle, but I think that's another thing that would be important. But in terms of service support in Bidjadanga, it would be improving the home and community care service we have.
Thank you, Dr. Fox. Commissioners, that concludes my examination.
Thank you, Ms Hill. Can I just explore a little further the concept of continuity of care? Because in your statement, you made reference to the fact that you provide services to a lot of people who come into Broome periodically and presumably drift off back to country. And the related question, of course, relates to trust, because from what you've said, you've got to have ongoing association with someone to build up the requisite degree of trust. Do you find it difficult when you're only seeing people once a year or?
Yeah. It's incredibly difficult and difficult for many reasons. So there's lots of things that interplay with that in terms of the communication between service providers, which I also talk about in my statement a little bit, that make it really difficult to be able to provide adequate care for somebody that's just come in from another community, and it takes usually takes up I'm the type of person that likes to be prepared and to be able to know as much as I can, and it takes up a lot of my time trying to find out information about where that patient's from, what their medications might be, and how I can help them. Yeah, that is the same in Broome and Bidjadanga. And in terms of the trust, yeah, it's lost, isn't it? When there's, well, not lost, but you've got not a lot of hope of building up a significant amount of trust if you're seeing a patient on a once-off basis once a year. Yeah.
And that leads me to a related question, and it's this: if you're trying to find out as much as you can about a patient's medical history, how are medical records managed in a remote area like this?
So we have an electronic system called MMEX that is, so there's a lot of, different care providers use different systems. MMEX is one that's used by all of the CAMS clinics, so it's a lot easier to, not significantly easier, because even though I might have access to an MMEX file, I don't necessarily have access to that patient's MMEX file from Halls Creek, and I need to get the patient's consent to be able to access their file in Halls Creek, which is a whole process of getting that done, and isn't usually able to be done on the day. It would take days and sometimes longer to be able to get that. But having a patient from the same CAMS, MMEX clinic is easier, but when it comes to somebody that's from a WACS, Western Australian Country Health Service clinic, or another clinic, then it becomes incredibly difficult, and that's where we rely on picking up the phone and trying to get in contact with someone from the clinic, or sending over
for just to take a practical example, you've seen somebody from an outstation you've hardly had contact with, but you've diagnosed some problems. You know the person's going back to that station. If the flying doctor has to come to provide some treatment to that person at a later date, would the flying doctor have access to the records that you've taken?
They wouldn't have access to the records, but the way that so if that patient was from an outstation that was out of Bidjadanga, it would be the Bidjadanga clinic that would be the people, which is a whole other level of complexity, that would be providing that emergency care for the patient. So, if they could get into Bidjadanga clinic, and that would mean that I would be the doctor that would be calling and speaking to the RFDS and giving them the information over the phone, there's quite a structured way to do that. But if it had to be, so say it was an outstation where it wasn't a Bidjadanga doctor or clinic that was providing the care, then that's RFDS have an incredibly complex job, because they sometimes pick up people, fly to remote outstations to pick up people without having, with only having spoken to the individual themselves or a lay person, and so they wouldn't have access to any medical records.
Must make it very difficult to provide care. We've heard a lot of evidence about the difficulties aged Aboriginal people have of accessing entitlements under my aged care, a lot of it being caused by their inability to provide various forms of records, including medical records. Do you get called on from time to time to provide reports for elderly patients with a view to getting such entitlements for them? And could you, if so, could you tell us how you see the system working? Do you have trouble dealing with it, or?
I have to say I don't know. I haven't had a lot to do with the new My Aged Care system, but I have had to provide medical reports for it, but I haven't had huge conversations with people about the complexities of it. I am aware that it doesn't work well and that there's long wait lists to be able to get access to care, and I think the idea that it's online makes it really difficult as well for patients, especially remote patients that may not have that kind of literacy or even a computer or phone available to do that. But I'm not. I don't have a lot of experience with it, so I don't know if I'd be able to comment past that.
And one last and different matter. How do you manage with pharmaceutical matters? Do you have a pharmacist who travels with you to the clinics?
No.
And how is medicine dispensed once you've prescribed something for a patient?
Yeah, that's a really valid point. So I don't think I mentioned it much in my statement, but in Bidjadanga there is a small pharmacy that is run by the rural area nurses and the GPs that are down there, with the help of Kimberley Pharmacy Service, which is a Broome-based pharmacy service. A pharmacist will travel down to Bidjadanga once. I think they're trying to do it once a month at the moment to provide that support, but largely the clinic is run by no on-the-ground pharmacy support. There's a certain amount of medications that rural area nurses have access to be able to dispense and supply without needing to have a doctor do them, and there's very rigid pro forma for those medications and the times in which they would be able to supply them, and then it's GPs that are doing the rest of the medication dispensing and supplying. There's always Kimberley Pharmacy Service are very supportive, and there's always over the phone support if you need support from it as well.
It must be very hard to encourage your patients, the elderly patients, to take their medication, and I assume that's part of the role of the community nurse to follow up and see that the medicine's being taken as prescribed?
So I think that's everyone's responsibility, and it's an ongoing issue that we have, and I don't think it's unique to Aboriginal people. I think I would struggle to take the amount of medicines that some people are expected to take. I struggle to take a course of antibiotics properly. So I think, people not taking their medications as ideally we would like them to be taken is a big issue. And in terms of the advocacy to try and promote that is everyone's responsibility, and everybody is aware of it, and it's something we are constantly talking to patients about, which comes back down to that health literacy and understanding the reason behind why we want people to take those medications, making people feel comfortable to tell us if they are having side effects from them that are stopping them from taking them. When the pharmacy the pharmacist that will come down once a month is really trying to do some advocacy efforts there as well. So having their own separate, consultation with a patient to talk about their medicines and to find out some of those things that GPs and nurses and health workers don't always have the time to do. So it's really tricky. Yeah.
one of the additional complexities of rural medicine.
Yeah.
Dr. Fox, it's been fascinating just hearing about how things are dealt with the need to adapt medical practice to suit the environment in which it's being provided, and we're very grateful to you for taking the time off what I'm sure is a very busy day for you to come and tell us about it. Thank you very much.
No worries, thank you. Thanks for giving me the opportunity.
We will take a short break while a video link is established to Darwin. Yes, Miss Hill.
If the Commission pleases, I call Ms Rosalind Millay, who's appearing from Video Link in Darwin.
Yes.
The audio is currently on mute, so we're not able to hear Ms Millay at the moment.
Hello.
Good morning, Ms Millay. Ms Millay, have you just taken the affirmation, or are you about to do so?
I'm about to do so,
Thank you.
Michelle. I solemnly and sincerely declare and affirm that the evidence that I shall give will be the truth, the whole truth, and nothing but the truth.
Thank you, Ms Millay. Ms Millay, I want to start by asking you some questions about who you are. What is your full name, Ms Millay?
My name is Rosalind Millay.
And whereabouts do you live?
I live in Broome.
And what do you do for work?
I am a project officer researcher for the UWA's Centre for Health and Ageing.
And have you prepared a statement dated the 2nd of June 2019?
I certainly did.
And do you have a copy of that statement in front of you?
Yes, I have.
And are the contents of that statement true and correct?
That's correct.
Are there any changes that you'd seek to make?
No.
Commissioners, I tend to that statement with document ID WIT stop 0174 stop 0001 stop 0001.
Yes, the witness statement of Rosalind Millay dated the 2nd of June 2019 will be Exhibit 4-15.
Ms Millay, before I ask you further questions, was there anything that you wanted to say to the Royal Commission this morning?
Yeah. Yes, I do. I'd like to acknowledge and pay my respect to the traditional owner of the country we are meeting on, which is the Larrikey and the Yarra Nation, to their elders past and present and emerging. I also would like to extend my knowledge and respect to the stolen generation and to their families, and also to all of older Aboriginal and Torres Strait Islander people in Australia.
Thank you, Ms Millay. Ms Millay, in addition to your role at the University of Western Australia, you are also the co-chair of the Aboriginal and Torres Strait Islander Australian Association of Gerontology Ageing Advisory Group. Is that right? Commissioners, the link appears to have paused.
Well, we won't leave the bench just for a minute and see if communications can be restored, and if not, if it's going to take a little time, we'll adjourn and you can tell us when we're ready to come back.
Thank you, Commissioners. We just lost the link there, Ms Millay. Can you see and hear us still? Are you able to see and hear us, Ms Millay?
I can see you, Ms.
We're just having a few glitches with the link. I was just asking you about your role with the Aboriginal Torres Strait Islander Australian Association of Gerontology Ageing Advisory Group. Are you the co-chair of that group, Ms Millay?
Yes, I am.
And Ms Millay, did you grow up in Broome? It's whenever this is on.
It'd be there then, because Broome is not a very good, like, unless, and
We're just going to try another solution, Commissioners. Commissioners, I believe the efforts are going to be made to make the connection by telephone. If we could just have a short adjournment to make
Yes,
those
we'll
arrangements.
adjourn temporarily if you'll arrange for our associate to be told when we're ready to resume.
Certainly, Commissioner.
All stand. The Royal Commission's briefly adjourned.
I'm sorry, Miss Malay, that you've been incommoded while we've sorted out this problem, but we think we've fixed it and we can get on with hearing your evidence. Yes, Miss Hill.
Thank you, Commissioner. Ms Malay, could I ask you to tell the Commissioners about your family background?
I'm a member of the Yuriyangamdam Gidja clan group from the East Kimberley. Hang on, excuse me. Oh, can I just take a minute there, Miss Hill?
Certainly.
When you're asking about my background, what is it specifically are you asking me?
Did you grow up in Broome, Ms Malay?
No, I didn't. No, I didn't grow up in Broome. I was raised out on the station, and then we moved into Halls Creek, Turkey Creek, then to Halls Creek.
And when did you move to Broome, Ms Malay?
And excuse me?
When did you move to Broome?
I moved to Broome 30 odd years ago, back in 1984, and I've lived there all this time.
Are you able to describe the relationship you have with communities in the Kimberley?
Hang on. Can I just find my notes?
Certainly. Perhaps if I can take you to paragraph 6 of your statement, Ms Malay.
Yes, I'm sorry. I've been key to the team by completing of all fieldworks in various communities across the Kimberley region. I have a wealth of cultural knowledge and mentoring and advising non-Indigenous colleagues about cultural consideration and ways to engage with community around research.
Could I ask you then to turn to the last page of your statement, Ms Malay, at paragraph 57? And could I ask you to read that?
Well, I am well known throughout the Kimberley region for the work I do in researching an older Aboriginal health. I am recognised as a role model and a leader to my families, friends and in the community.
How did you establish those relationships, those connections to communities, Ms Malay?
My experience working in the remote community region is with my work role as a research and a project officer, I have with my work as a research and a project officer, excuse me, I'm a bit.
Please take your time, Ms Malay.
Ooh. I am one of the few Aboriginal research officers working in the Kimberley and has been instrumental in improving the lives and wealth of older Aboriginal Australians who live in the Kimberley. I'm a delicate and passionate about health and well-being of our older Aboriginal people. I have been involved in advising capacity in all projects that I have worked on. I have working groups to ensure that people of the Kimberley are representative. I have working groups to ensure that people of the Kimberley are represented. I have been involved in the communication and relationship building within the Kimberley region, as well as recruitment and participating in interviewing people within the Kimberley area. In summary, I have been the key researcher, contact person and advisor for the project within the Kimberley region. I am currently involved in running the Kimberley arms of several research projects that are looking to improve the health of Aboriginal and Torres Strait Islander people as they age.
What are people telling you about ageing when you go out to these communities?
Well, what are they saying is that there's a lot of challenges that they are facing due to lack of services. There's issues with communications. As you know, English is pretty much their third or fourth languages. Communication is a big barrier for them. Access to services is very hard. And I guess they want to see better services.
What do
And
older
the services that people provide, and that delivers the services to the communities.
Ms. Malay, what do older Aboriginal Australians tell you about residential care?
For older Aboriginal people, what they're saying about the residential care is pretty much a death sentence to them. It's not where they want to end up. They prefer to stay on country to be able to continue their leadership in the role that they play in the community. And that they don't want to end up in aged care because it's a death sentence, like I mentioned. And the thing is, the comment is, you go there to die. And they would rather stay on country and to die, if that makes any sense.
What do older Aboriginal Australians need to be able to stay on country?
Better service provider, better care plan, where all family and the community members are all involved in their care plan. Older Aboriginal people want to stay on country longer than they would otherwise, just to be ensure that they have family connection, they're still connected strongly to the land, law, culture, to be able to continue that and pass all that knowledge down to the younger generation.
Could I ask you to turn to page 4 of your statement, Ms. Malay?
Yes.
At paragraph 22, you say that there's an urgent need for there to be an Aboriginal and Torres Strait Islander employment strategy in aged care.
Yes, where I think local people often do not have the skills required to apply for certain jobs, or are not made aware of vacancy prior to them being filled internally. Racism is also a barrier for Aboriginal people entering the workforce. I believe that there's an urgent need for the Aboriginal and Torres Strait Islander aged care workforce employment strategy. Keeping cultural immersion and training for non-Indigenous employees, we need current leadership in the sector of promote cultural safety, first by working collaboratively with local Aboriginal tradition owner groups to increase the two-way sharing. We need cultural leadership in the sector to promote cultural safety, firstly by working together. We need employers to understand and respect Aboriginal employers' obligations such as attending sorry business and law business.
Thank you, Ms Malay. Do older Aboriginal Australians have cultural needs that ought to be addressed?
Yes, I believe so, definitely.
And what are they?
Language, trust, respect, spirituality, connection to families, to kinship. Gender plays a very big part in when you're caring for someone. Recognition of identity, who they are, respect them for who they are, who we are, I guess. Understanding the emotional and expression, for example, sorry business, dietary requirements, smoking ceremonies. And I guess it's end of the day, it's respecting their belief.
What does culturally appropriate care mean to you, Ms Malay?
Valuing and treating Aboriginal and Torres Strait Islander people as individuals, respecting their dignity, where culture is valued. In strength, spirituality, law, strong connection to families, like I mentioned, kingship, gender.
From what you were told, Ms Malay, does the current aged care system deliver culturally appropriate care to people living remotely?
From what I was told, the current aged care system does not deliver culturally appropriate care from few people that have been working in the aged care sector.
What are people saying to you about their experience in aged care?
People are telling me that some of the issues that they are facing, there's no respect in gender treatment, gender care. When the accreditation is due, it's just tick the box. And there's not many Aboriginal or Torres Strait Islander employees to be able to care for their own people in these facilities. And it's due to racism. I was told that there was a lady who did her Cert 4 in aging was actually working at an aged care facility prior, and once she was qualified, there was no job, there was no longer a need for her service at the aged care. So these are the things that we are facing in our communities. Like I mentioned, racism plays a very big part to our health and well-being for our older people. I remember some time back, one of my family member had mentioned to me, we want to be able to care for our own people our own way. When I'm saying Gadias, it means white people aren't looking after our people the way they should be, the way they deserve to be looked after in these facilities.
How should older Aboriginal Australians be looked after, Ms Malay?
Excuse me, can you repeat that, Ms Hill?
How should older Aboriginal Australians be looked after in aged care? What's your way?
I think it should be our people, Aboriginal and Torres Strait Islander people should be allowed to have choices in regards to how they should be cared for.
Do they
culturally, respectful, trustworthy, to be trusted.
Are there choices for older Aboriginal people at the moment?
I don't think so.
And why is that, Ms Malay?
Because we still have a lot of older people who's not confident enough to be in mainstream aged care residential because of the treatment. They feel that they're not going to be treated with respect or how they should be treated.
How did you feel about giving evidence today, Ms Malay?
Very nervous, was very reluctant. Due to the fact that some time back I had given evidence to an inquiry and there was nothing done. It's fine all and well for us to sit here or for each and every one of us to give evidence in regards to our older Aboriginal and Torres Strait Islander people are being treated as they get older, and not to mention the stolen generation people, and we're not being heard. So I think what I'm saying here is I'd like, not only for myself, but I'm sure I speak on behalf of everyone, of all of us Aboriginal and Torres Strait Islander people, and also the stolen generation people, that we would like to see changes for the better. And I always say, every time I've gone out into the communities in my field doing my work, I would always make this comment that every older Aboriginal person needs to be treated with respect, with dignity, because they are the ones who are the keepers of our law, of our culture, of our land, who keeps us very connected to our land, our law, our culture. If they weren't here, everything would go pear-shaped. So I think in return, we need to respect our older people and giving them the best treatment and the best care in whatever years that they may or might have left.
Do you have any additional thoughts that you'd like to share with the Commissioners?
As an aged care workforce, there was something that I would like to mention there. I think that to better our services towards our older Aboriginal and Torres Strait Islander people, I believe that it should be Aboriginal and Torres Strait Islander governments run by us for our own people. I believe it saves a lot of taxpayers' money. We do it on our own. We don't need training in our culture. Our language wouldn't be an issue.
Ms Malay, do you have any concluding remarks that you would like to share with the commissioners here in Broome?
I would just like to, I mean, yes, just that I was reluctant to give evidence due to the fact that I feel that whether it's going to make any difference from the last time that I have given an inquest, evidence to the inquest.
Thank you, Ms Malay. Commissioners, that concludes my examination of Ms Malay.
Ms Malay, we're very grateful to you for giving us your evidence this morning. It is very important for the Commission to understand the views of elder Australians, and including Aboriginal Australians, as to how they consider they should best be cared for. And because of your experience and knowledge, you've been able to tell us those things, and they, I assure you, have been registered. We can't promise you action because our job is to consider the evidence and make recommendations, but we are very conscious of the need to accommodate the requirements of the Aboriginal community, and we will certainly take that into account in framing our recommendations. Hopefully, the government of the day will act on those recommendations and ensure that there are better services. In the meantime, may I make this suggestion, and it really appears in parts of your statement. It is so important as we move, hopefully, to a situation where elderly Aboriginal people are being looked after in a culturally sensitive way by younger Aboriginal people, that those people will be encouraged to undertake the necessary study so that they're there and available to assist their older brethren, so that anything you and others in the community can do to turn the minds of younger Aboriginal people to the desirability of training for these roles would be very important. We have heard some evidence about an aged care facility in the Torres Strait, for example, where 80% of the staff are Indigenous people, and they are providing just that sort of care. They've gone and got the training, and they're looking after their elders, and if we can spread that model, we think it would be a very good thing for all Indigenous communities in Australia. So may I leave that thought with you? I'm sure you've already considered the issue, but it needs to be spread around the community because the training is there. We just need Aboriginal people to take it up. But look, thank you so much for your evidence. We're very grateful. Do we need to adjourn briefly?
A short break for the next witness who's also appearing by video link.
Yes, very well. Thank you again, Ms Malay. The Commission will adjourn temporarily.
Thank you, Your Honour.
Yes, Mr Bolster.
Thank you, Commissioners. The next and final witness is Vanessa Michelle Curnow, who is on the video link from Darwin. If she could be sworn, please.
I swear by Almighty God that the evidence I shall give will be the truth, the whole truth, and nothing but the truth.
Might the document WIT 0243 001 0001 be brought up on the screen? Ms. Curnow, you have a copy of your statement there.
Yes.
And it's got at the top of the page that number WIT 0243 0001 0001, the top right hand corner.
Yes.
Okay.
Yeah.
Is there anything about that statement that you want to change or that you want to amend?
Yeah, there's just one minor amendment in paragraph number 3 where it says, I make this statement on behalf of Cairns and Hinterland. That should read, I make this statement on behalf of Torres and Cape Hospital and Health Service.
All right, thank you. We'll make that. We'll note that.
Yeah.
Now,
That's the only change.
all right, I tender that statement. Thank you, Commissioner.
Yes, the witness statement of Vanessa Michelle Curnow dated the 17th of June 2019 will be Exhibit 4-16.
Attachments 1, 2 and 3 to that are to be found behind tabs 82, 83 and 84 of the tender bundle.
And those attachments will, to the extent necessary, form part of the exhibit.
Thank you, Commissioner. Now, Ms Curnow, you hold the position of Executive Director, Aboriginal and Torres Strait Islander Health for the Torres and Cape Hospital and Health Service, correct?
Yes.
And you also are a board member of the National Congress of Australia's First Peoples?
Yes.
And you're a board member of the Congress of the Australian and Torres Strait Islander Nurses and Midwives?
Yeah, that's the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives.
That's sometimes known as CATSINAM.
Yes, that's the
Right. And you have a long history as a registered nurse in aged care in the Torres Strait, correct?
All across Queensland and right up to Bamaga, Thursday Island, remote areas across there, and have worked nationally as well.
And your heritage is from the Torres Strait?
Yes, I'm Aitkarel Samu, Torres Strait Islander.
And for those of us who are unfamiliar with that term, what does that mean?
Those are my two clans from Saibai Island in the Torres Strait.
Right, thank you.
Kalalagaoya language group.
Just stopping there for a minute, the language groups in the Torres Strait, how many are there?
There's about 5 different language groups in the Torres Strait Islands.
And how much of a difficulty does that present when it comes to people coming to Thursday Island and elsewhere to get aged care and primary care?
Well, particularly for older people, it's difficult for some of them who've never been off community, who predominantly and talk their native Torres Strait Islander language. And so when they need to access Western services, it's hard for them to understand fluently what people are saying in English, and particularly when they start talking in medical terms, it gets even more difficult.
All right, well, that's probably the first barrier to accessing aged care that we're going to talk about. What are the other barriers that are significant that the Royal Commission should take note of?
Do you mind if I, before I go on, Paul, just acknowledge country as
certainly,
protocol?
yes.
Yeah, thanks. I just wanted to acknowledge the country on where we're meeting, both here and over in Broome as well. but particularly for Aboriginal and Torres Strait Islander people all over Australia, as the Royal Commission findings and proceedings pertain to our older and elders across Australia. And I'd also like to acknowledge particularly our elders and older people and our ancestors who've led the way and built what we have today, and particularly acknowledge the stolen generation who are removed from culture and who are ageing, as this Royal Commission findings will affect their lives as well. And of course I need to acknowledge my Aboriginal and Torres Strait Islander colleagues in aged care as well, some of whom have been burnt out by the system and are no longer working in aged care, but have made amazing contributions to where we are today in aged care, in Aboriginal and Torres Strait Islander aged care, and of those that are still working in aged care who continue to provide their skills to aged care in some of the most difficult operating environments to make sure they look after our old people.
Thank you very much, Ms. Curnow. If we could go back to the barriers that people face when they access aged care in remote locations, particularly North Queensland and the Torres Strait Islands where you're based, what are the most significant things that the Commission needs to consider?
In the Torres Strait Islands, just to give a geographic understanding for people who haven't been there or have only seen it on a map, there's a whole range of small islands between the tip of Australia and we share an international border with Papua New Guinea. And these islands would have groups of people of 1,000 or less people living in small villages on some of these islands. Some of the islands are facing climate change issues. So there's also issues around food security and just general development as well, in terms of lower rates of employment, lower rates of education attainment, poorer infrastructure, less access to markets to build economic development opportunities and foster new jobs and employment and businesses and things like that. So that's the context of Torres Strait Islands, and then Cape York is four-wheel drive accessible all of the year, and in part of the year in the dry season you can drive up to all areas of Cape York. So for about half the year it's inaccessible, even with a four-wheel drive due to flooding. It's about 2,000 or 1,600 kilometres to the tip of Cape York from the nearest regional centre. And then from Torres Strait, there's another couple of hundred kilometres to the international border. So there are barriers around infrastructure, general access to everyday living, food supplies, electricity, internet, the things of daily living, but then add a layer of access to healthcare and personal care and support for older people who are vulnerable and need extra help. That adds an extra layer for them, to be able to access an ATM in a local community that might not have wheelchair access footpaths, or be able to maintain a quality of life because they haven't got a wheelchair that can go down to the beach, so they can join their family to go down and enjoy what's good about living in a remote part of Australia, and those sorts of things. So it has a lot of unique challenges, definitely.
You talk in paragraph 24 about looking towards economically viable models for infrastructure that support local aged care. Could you speak briefly to what you mean by that?
Well, in this paragraph, I described a model that would look how it would be the responsibility, more responsibility would, and this is my personal view and not the view of the Hospital and Health Service or the state in which I work, would be around being the responsibility of government to work across agencies and across departments to look for those efficiencies in infrastructure funding. So if housing has an allocation of money, or roads have an allocation of money, or the Northern Australia Collaborative has an allocation of money for infrastructure, that there within those collaboratives there's a thought put to local planning around what will be the aged care need in a local community, and that when they do go to build a house, which they're going to build anyway because they've got an allocation of money for housing, that they think about how that house could support someone to age well at home in the community for as long as they can. Would they have the internet access in that home so that they could have an alarm system in that home? That there'd be wheelchair access, that there'd be intergenerational living, so a carer could live in the same house as an older person. Or in this example, that's considered with local council and housing cooperatives around how they could maintain the buildings, and that the care and services that are provided through Department of Health and Ageing be funded to go in to provide the services, but the housing component is funded by housing, and that local council have particular housing for older people or people with disabilities. But then as the ageing population demographics change of that local community, if they don't have that many older people who require housing, that could then be rented to a young family. So it's an adaptable housing model. It's still housing stock because we've got hardly any housing stock, but that housing stock is adaptable enough that it can meet a vulnerable population's needs as well, which is not, all other houses could meet any person's needs in community, but aged people need a particular kind of housing stock where, it's got wheelchair access, it might need to house a carer, could have that telecommunication link for, 24-hour emergency access, and those sorts of things as well.
Thank you for that. Could we turn then to workforce-related issues? What's missing from policy when it comes to the training and education of Aboriginal and Torres Strait Islander peoples in the aged care workforce?
Yeah, well, the Department of Health brought out an Aboriginal Torres Strait Islander health workforce strategy, and I make reference to it in my statement. I'm looking for the correct name for it.
Paragraph 32.
32, thank you. And it seems to have fallen off the radar. And doesn't, it talks about the health workforce but doesn't talk about the aged care workforce, because when you look at Aboriginal and Torres Strait Islander aged care workforce, you need to look at it in the context of Aboriginal and Torres Strait Islander developing communities, developing economies, and the poor outcomes that we experience across a whole range of areas. And the way that we're going to overcome some of those issues is that using a local development model, community development model, and having that co-design with Aboriginal and Torres Strait Islander people so that they can incorporate culture. And so, not to go off subject, but this this is the reasoning why we have an Aboriginal and Torres Strait Islander health workforce strategy. And they've considered all of these things, but what's missing from that is the aged care component, which we could get some efficiencies if we could, be included in a health workforce strategy, because a lot of our, health professions provide services in aged care services the same as in healthcare services as well. If we could get more registered nurses, more allied health people trained, doctors, as well as management and admin people, we could have efficiencies if that health worker workforce strategy was, if aged care was included in that. And so the Indigenous health workforce strategy talks similarly about the infrastructure issue. If, we could get that cross-agency collaboration, so between the Department of Training and Education, Prime Minister and Cabinet, who previously, I don't know who holds the portfolio at the moment for Aboriginal and Torres Strait Islander affairs, we're talking amongst each other, then we can have joint initiatives around workforce, because we know we've got close the gap targets in unemployment, we've got close the gap targets in health outcomes. So it would make sense that they prioritise work, which we've got vacancies in, to have Aboriginal and Torres Strait Islander people trained up in those areas, so you could then reduce unemployment, but also then have our own people working in healthcare or aged care, which then provides safer health services, improves access to health services. And because I didn't mention before around the barriers to aged care, there's also soft barriers as well, not just the physical barriers. There's barriers around cultural safety. If a person isn't able to communicate with a clinician who's got, a master's or a PhD and an amazing, education background, that person still may not be able to understand what they're saying or access their treatment, because they might not have the skill in cross-cultural communication, or not be able to understand the context of what that person's circumstances are and how they're living, and how they're able to access care and services.
Could I ask a question about, in the Torres Strait, training for nurses and carers, particularly Indigenous nurses and carers? What's the state of participation of the local Torres Strait Islander people in aged care training?
Previously we had a high rate of participation, and it was because we had, I want to say it was in the mid-2000s, dedicated allocation of funds for remote and Aboriginal and Torres Strait Islander training, and those funding allocations were given out to the registered training organisations, who then needed to engage with service providers to find out what their training leads of staff were. So it was still particularly targeted at existing staff. It wasn't for recruiting new staff, and it wasn't for pre-vocational people. But that worked really well, because they were then, the RTOs were responsible for developing local training plans, changing the delivery of training to suit local communities, and they were then sort of charged with or accountable for being able to for education attainment rates then. So the people that more people are able to support to get qualifications, they were able to sort of then acquit their funding that they received from the Department of Ageing back then. So that worked really well, because there was that partnership between the RTO and the service provider, and the industry and the service provider, and the training was then made more appropriate to local needs, not just for the skill set that was needed for the old people and their care needs, but also for the older, the adult learners and how they learn best. But just in the last month or so, we've in Torres and Cape engaged a partnership with James Cook University and the Pro Vice Chancellor of the Indigenous Faculty, Professor Martin Nakada, and part of that work was where we're looking at a collaborative between education and industry, ourselves in health as service provider, to look at how we could improve the Aboriginal and Torres Strait Islander participation and qualifications in our workforce. We've got a population of about 60% Aboriginal and Torres Strait Islander people in our catchment, but we only have an employment rate of about 12%. So we're looking for our employment rate to reflect what the population is, and not to mention that we have an unemployment rate of about 30% in some areas higher. So, and as part of that, they've done a mapping exercise where they've looked at what is available, and it's a continuum for, to look at, really early on what the curriculum looks like at the high schools in remote areas around STEM, and how kids are ready to be able to, apply for undergraduate courses in universities and become health professionals, but also whether we can offer a vocational path for those who don't want to go down the academic professional path and really want to do a sort of a trade in aged care or nurses' aides or allied health aides or something like that. And so there's only, I think, 3 high schools in our area and RTOs that offer that. So 2 at that year 11 level. So that's something that will come out of this initiative, is developing those pathways and strengthening our relationships with the high schools and the RTOs around the curriculum strengthening, offering of the vocational pathways from high school, and then tertiary access support that's needed to stay in university, to enrol in university and stay in university for the whole course. And that's something that we've done without any extra subsidy, and we're at this stage looking for how we could support that across agencies and hopefully not have to equip to 5 different departments or something like that.
Could we turn to a different topic? And in paragraph 33, you reproduce a diagram that emphasises the importance of country. I wonder if you could talk briefly to the takeout that we, who are less familiar with these concepts than you, what should we draw from the approach to country for your people?
Well, yeah, this diagram is a really simplistic way to try to explain across cultures how important country is to Aboriginal and Torres Strait Islander people. So country is the circle in the middle of the diagram, and country is also the circle on the outside of the diagram. So country is central to who we are and what we do, and it also encompasses us as well. Because then from country we've got Aboriginal and Torres Strait Islander individuals, and then we've got our family, which is our broader networks and community, and then what encompasses all of us is country. So it's central to each of us as individuals, but as a whole, it encompasses us all as well and keeps us safe, feeds us, gives us shelter, and even has a spiritual aspect around as well, around a place of belonging and feeling and having feelings. All of the stories are passed down as songs, dances, which are really emotive, and there's some research that's coming out more regularly now, and I think we all know it innately as well. You can remember a jingle to an advert, when you were a child, kind of thing, and it still sticks in your memory because those sorts of things are easily retained in memory and easily recalled in memory. And so we taught stuff through dance and song and stories. It has a beginning, has a middle, has an end. It has legends have a way of eliciting people's emotions and tying them emotionally to something. So our connection to country is not as a physical resource. It is partly as a physical resource. Yes, we know we need to get food. We know we need shelter and those sorts of things. But at the same time, we have a story about an animal, and we end up with a spiritual connection and a belonging to an animal or a place. We have a story about a place, we have a song about a place, we have a dance about a place, we have artwork about places, and it's all around country and our connections to country. It's also about the rules of country and how, we've got 400 different peoples or more living across Australia, different Aboriginal and Torres Strait Islander people. So we all have borders everywhere between different places. We didn't kill each other before colonisation. We didn't start mass wars to take over other men's countries, but we also uniquely understood that if we poison water up in a water source above another man's country, that'll kill their food source down, and that could start a war. So there's a lot of stories around not necessarily saying, don't poison food. There's a place where you don't go and you don't do. There's a song to it or a dance to it to explain that that's got to be passed down through a generation and the next generation as the same story, so that nobody gets it wrong, and it's quite strict.
Now, you say in paragraph 34 that you see culture as a means of group survival. Could you
Yes,
expand on
yeah.
that just briefly, please?
Well, we innately trust in it. Aboriginal and Torres Strait Islander people innately trust in their culture. They trust in their languages, and it may from the outside seem easier for to go down a Western lifestyle and live that way, but there's not that trust in that way of living. If we do rely totally on a Western way of living, we'll lose our way of hunting, our way of gaining our own food security, our way of living together, of knowing who our collective cultural insurance is, how our families look after each other. We can't be isolated from each other, which is what a Western culture, sort of like popular culture, has as, their values and beliefs around, buy your food from the shop, have, small families and things like that. Ours are it's a different way. We trust that those cultural practices have kept us surviving for this long, and even actually kept us surviving through mass colonisation as well. So we have faith in them.
Can I turn then to the culture surrounding the family and the need to, or the obligation towards the older members of the family? Could you speak to that, please?
Yeah. Looking after old people is just, we've got cultural practices that help us to, and rituals that, remind us that old people are an important part of our lives. So it's sort of inbuilt in us from a very, very, like, you just grow up in it from when you're young. So the old people are the ones that teach you how to go out on country. They teach you all the songs, they teach you the languages. So you have an innate respect for them and their place in community. There's an understanding that we generally, that we wouldn't be here without the older people. I know that, there's instances, as there is with any culture, where, there's elder abuse or things like that, but generally is our cultural belief, like looking after our older people is part of who we are, and them having a relationship with the young people, it's like our connection to their mother and their mother before, and that's how we pass down our knowledges through the generations. So they'll tell you stories about when they were young, and that's your connection to your grandmother, or when your grandmother was young, and that's connection to your great grandmother. Like you hear the stories of that have been passed down through time, and that's part of our culture as well.
How do you engage that?
It's innately.
Sorry, the time gap is annoying. How do you engage that custom, that sense of obligation in delivering aged care?
Well, because we practice our culture, it's innate in our. If you've got an Aboriginal and Torres Strait Islander aged care service, it's just part of your interactions with the old people that you're looking after, and the old people who access our services, they're family members of staff, they're family members of management, they're family members of the board of directors. So, we're interrelated. We all then know where each other's from generations ago, how we've intermarried, and then we've got obligations to each other to look after each other. And because we come with that belief, and we have that shared belief that we, that older people are important in our culture and important in our societies, that we should look after them because they've looked after us, that it's part of our aged care services, whether it be community aged care packages or residential services. No matter what the way we provide services, we make sure that culture is part of it, and it's not necessarily written in a policy or procedure, it's just practiced, and it's part of the flavour of or the organisational culture of services.
I want to develop that to the concept of culturally safe care. How do you, you obviously work for the government and you're involved in the delivery of important healthcare services to a lot of Indigenous people, including older people. How do you make sure that culturally safe care is actually delivered on the floor of a hospital, on the floor of a nursing home, in home care? How do you do it?
Well, you know, for us it would be employing Aboriginal and Torres Strait Islander people, and you know, there's a lot of evidence. So, in my current position where I work in a non-government organisation, I spoke already about how we are trying to improve our employment targets of Aboriginal and Torres Strait Islander people to reflect, you know, the population. But in and I've worked for many years in Aboriginal and Torres Strait Islander aged care services. Before working back with Queensland Health, we just encouraged employment of Aboriginal and Torres Strait Islander people, and some of the things we did to encourage people to apply for work in aged care was that we've got like a lot of informal carers, unpaid carers who are family members. So we recognise that they already have a skill set, they're already delivering care, they already have an interest. So we might then just employ them for a certain amount of hours so that they could get some pay, but also then we then support them to get qualifications if they were interested. And then if their care and responsibilities for that person change, they might work full-time back in the aged care service. So that was one way we'd encourage people to come and work for us. But really it's about and there's a lot of evidence around that as well. I think the Indigenous Business Australia put out some data that Aboriginal and Torres Strait Islander people are more likely to employ Aboriginal and Torres Strait Islander people. So that's just part of our operating. You know, we understand that they've got that skill set that you can't teach people as well. You can teach Aboriginal and Torres Strait Islander person about mainstream caring, how to lift people, how to turn people, you know, what type of medications to give and when, but it's harder to teach a non-Indigenous person cross-cultural skill sets, because that's the kind of things that you learn over a long period of time. And cross-cultural cultural safety is at the one end of the continuum. You start off at cultural competence, awareness, and then move on to cultural competence, and then hopefully over time people can get to cultural safety, but it's a skill set that's built up over a long period of time. It requires immersion and a lot of exposure to culture, which unless you're living in the culture every day, it's much easier to have an Aboriginal and Torres Strait Islander person employed than it is to teach someone all of those nuances, particularly because we've got such a diverse range of cultures as well. There's so many different Aboriginal and Torres Strait Islander cultures, and even for an Aboriginal and Torres Strait Islander person, we then have another skill set around that cross-cultural communication. So we might not necessarily be from that specific cultural group, but we understand some of the commonalities, but then we're also able to adapt our practice more easily to suit the person from a different culture as well. I think that answered all of the question. Yeah.
I wanted to conclude with giving you an opportunity to identify 3 or 4 or 5 key things, key points that the commissioners should look at when they're making their report to the government. What would you counsel them to do?
Yeah, I think the really big thing is that we also recognise that our Aboriginal and Torres Strait Islander people, older people and now elders, like I say, are the links to a knowledge that's been built up from time immemorial in Australia. So we've built up in living so close to the land and having that connection to country, traditional ecological knowledges of where, around when different seasons, different food sources, which type of plants have medicinal properties, which type of plants have nutritional properties and things like that. So there's a whole internet. It's not even an encyclopedia of knowledge amongst these older Aboriginal and Torres Strait Islander people that we just don't even have access to in our schools to teach our kids, or to help to be part of Australia's food security, because we all know that that's going to be a big issue around water security and food security for Australia over time as well. And what will happen is that these people will pass away and that information won't be captured because of it gets harder for us to maintain our culture outside of institutions and outside of infrastructure. So if there were methods to bring that into our institutions, our schools, our universities, into our aged care services and programs as well, and there was proper support and recognition that this stuff is valuable and that it actually exists, because I don't even think people really know that it exists. That would be the big take-home point, I think, for the commissioners. But one method that we could use to actually progress that would be to have investment in an Aboriginal and Torres Strait Islander elders and older persons collaborative research centre to build our evidence base and communicate across industry, clinicians and government departments how we as Aboriginal and Torres Strait Islander people would like to care for and support our older people and elders, and how we can re-strengthen our cultural practices and languages to ensure traditional ecological knowledges of Australia are an integral part of Australia's national development, and especially a critical part of protective factors to close the gap for Aboriginal and Torres Strait Islander people in multiple outcomes, not just health, but also education, employment, and better functional relationships and interdependence. So helping to support our older people to stay in communities and fulfil their role in relationships and their vital relationship in maintaining our humane qualities in our societies as well, such as how to be patient and how to care for people, is really important, and they shouldn't be locked away somewhere. They should be enabled to, be part of our communities and our families and how we look after them, and we can keep our cultural practices of looking after them. So the name of the Collaborative Research Centre should not be ageing. It should be Aboriginal and Torres Strait Islander elders and older persons, because the research is more than service provision models. Although there could be projects that highlight viability solutions in Aboriginal and Torres Strait Islander aged care service provision in thin markets, and also about ageing processes as well. But it would be more about the older people themselves and recognising how critical a contribution to society they are, and not a burden, because without them we wouldn't be here today. And they are living connection to a wealth of wisdom and lessons and experience of stories of traditional ecological knowledges, cultural practices and fluent language speakers.
Thank you so much. Commissioners, I don't have any more questions.
Ms Curnow, we understand you're involved in a very important conference at the moment, and we're more than grateful that you've taken the time out to provide us with some insights into the culturally important issues that arise in relation to the care of elderly Indigenous Australians. We're most grateful and thank you.
Thank you, Commissioner. Thank you, Commissioners. Yeah.
Are we going to take a break?
I thought we'd proceed, Commissioners, if that was...
Yes, very well. Well, we'll break the connection to
thank you,
Darwin, and thank you again, Ms Curnow.
Commissioners, that concludes the evidence for the Broome hearings. Since the beginning of this week, the Royal Commission has heard direct evidence about how aged care is being delivered at multiple remote and very remote locations through various models of care within the three largest states, Western Australia, Queensland and South Australia, as well as the Northern Territory. You heard evidence from Madeline Jadai, who told you about caring for her sister Betty in the remote community of Bidjinjanga. Within the same community, you have heard how Faye Dean and her staff pick up the clients each day, collecting the washing before taking them to the community centre where meals are provided. There's access to showers and laundry facilities. People are supported to access health services and social services. And there are visits to country as well as social activities. This model of care is mirrored in the direct community-based care that is provided by Mr Aitken's organisation within the APY lands of Northern South Australia. The care delivered in these locations is respectful and delivered by people who are embedded in and who are part of the community and who truly understand the cultural needs of the recipient. Trust and mutual respect are evident. This model of care is different to the form of aspects of home care described in previous hearings. Rather than care being provided to the older person in their home, it is provided in a community centre or a care centre. It is a model of care that is provided in a context where residents do not have any realistic or close access to residential care in their local community. In the evidence concerning facilities at Derby, Fitzroy Crossing, at Docker River, in Broome and on Thursday Island, you have seen a cross-section of how residential aged care is delivered in remote and very remote regions and with a focus on Aboriginal and Torres Strait Islander peoples. A sizable proportion of these facilities have largely been taken over by the current providers following the failures of their predecessors. You have heard that these providers are there because if they were not, there would be a very real question about whether any service could continue. With varying degrees of success, these facilities all seek to endeavour to deliver culturally safe care to those for whom they are responsible. As we said in our opening, a principal focus of this hearing has been on cultural safety, and we wish to close with some observations about that central issue. Broader policy matters surrounding funding structures in their various complex forms, broader workplace-related issues, labour market supply and demand, and police checks are beyond the scope of these brief closing remarks. However, we do wish to outline some of the themes that surround and frame the issue of cultural safety. Can I begin with what Mr Aitken said about cultural safety? To quote him, "In our eyes, there's been lots of research and papers written about cultural safety. In our eyes, the judge of what cultural safety is the individual. We will speak to the elder about what they need for us to be culturally safe, appropriate, or whatever. It's an individual conversation, and it's a respect that we treat everyone as an individual and with dignity, and to us, it's what cultural safety is all about. For Dr. Fox, cultural safety is a whole topic of its own and should always be defined by the people that are receiving the care. Providing culturally safe care is about having an awareness of the underlying issues, cultural and social and emotional issues, historical issues that affect that person's relationship with you. Against that backdrop, it needs to be remembered that there is little, if any, money to be made in attempting to deliver aged care services in remote and very remote Australia. This is clearly borne out by the absence of for-profit providers in the areas under consideration. In remote locations, the costs of food, transport and staff combine to force providers to operate at a loss. Where the facility is part of a larger group, an operator may be able to absorb these losses with revenue from more profitable facilities. However, for smaller independent providers, the pressures must be enormous. The warning of the Aged Care Financing Authority regarding the viability of regional and remote providers referred to in my opening bears this out, as does the evidence of Mr Priest regarding the losses at the Juniper facilities in the Kimberley. It must therefore be recognised that the organisations that operate in remote and very remote regions continue to do so because of a commitment to provide care. In many cases, this commitment is the result of historical service delivery in the area and an organisational commitment. In broad terms, that commitment would seem to extend to the delivery of culturally safe care. There is, however, a degree of uncertainty, a lack of direction, and a lack of uniformity as to approach when it comes to doing that. Put another way, whilst the new aged care quality standard makes express reference to cultural safety, it would seem relatively clear that the concept is understood as meaning different things to different providers. For Mr. Aitken, it means delivering services that acknowledge, value and respect the elders' cultural identity and working with community to do so. It follows that where care is provided to any significant portion of Aboriginal and Torres Strait Islander people, the evidence at this hearing indicates that it is essential that there is a real focus on the following matters. Firstly, understanding the location and the people who live there. This involves understanding the role of the elders within the community and in particular their responsibilities towards the community. As Ms Bridges pointed out, the care needs of Aboriginal and Torres Strait Islander people are intimately connected to family, community and culture and language. Secondly, it involves responding to the particular needs of the community, recognising that the community is likely to have an embedded collectivist culture where there are obligations owed by and to the elders. Mr Aitken explained the process of consultation that's required in these terms. We were respectful in our conversations with community about what we were wanting to achieve in terms of aged care service delivery, talking to as many different people as possible, and certainly the elders has really helped us not only establish our service provision, but also enabled the elders to really understand what it is that we were trying to achieve. And by dealing with the elders in a respectful way, asking them how they wanted us to do business, we've been able to get to a place now, and we're still developing and improving all the time. This is typified in the requirement of the communities in the APY lands for community employment in service delivery. As Mr Aitken put it, the employment outcome, employing people related to the elders to be cared for, is what the community was after. Thirdly, there is a need to obtain the trust of the community by respecting cultural matters. This is most likely to arise in the context of what are loosely referred to as cultural responsibilities and the need for Aboriginal and Torres Strait Islander staff to return to the community for sorry business and other cultural matters. It is also likely to arise when it comes to traditional ceremonies surrounding the passing of a resident. Fourthly, where the provider is a non-Indigenous organisation, one way to demonstrate and ensure cultural safety is through having a high level of Aboriginal and Torres Strait Islander staff delivering care. Where there is local engagement with the community by the care provider, either through a partnership arrangement like that which operates in the Kimberley, or even through community control like in Bidyadanga and the Luma projects described by Professor Flicker, the outcome is likely to be far better. Ms Bridges, who is associated with both Thursday Island and the Docker River, described the partnership in these terms. Partnership is critical to understanding the needs of the people we care for and providing them with dignity and deep respect as they age. Professor Flicker noted that where the care provided is not culturally safe, Aboriginal and Torres Strait Islander people will be reluctant to take it up and may in some cases refuse care. Ms Crawford expressed a similar view. She said, if you don't have the trust of the communities won't let you visit. They won't listen to you when you go, and they don't want to work together with you. So having the trust of people in the communities is really important. We're very fortunate in CACS. We have, out of our 31 staff, we've got 9 that have been there for 10 years or longer. Faye Dean, when asked about the most important thing in delivering care, had this to say: respect again and dignity. You go, very slowly. You go at their pace. In the context of the project at Luma, Professor Flicker attributed the success of that project to trust and ownership and respect. He said that the community had been listened to and that the service that was delivered was a service that they wanted. He talked about the need to earn trust against a backdrop where there is little to commend the Aboriginal community to trust the rest of us. He pointed out how this might explain why Aboriginal and Torres Strait Islander people do not immediately accept that the person in authority is there to do them good. In his words, the legacy of the stolen generations presents a stark reminder of why Aboriginal and Torres Strait Islander people won't necessarily trust non-Aboriginal and Torres Strait Islander people. Ms Bridges observed that it takes time to achieve and requires staff to spend time outside direct service delivery, engaging with families and elders. She pointed out how relationships are built over time and again how turnover of staff can affect the situation. At paragraph 66 of her statement, she said this: for many Aboriginal and Torres Strait Islander people, there is a distrust of institutions and a reluctance to enter care. This distrust results from the history of marginalisation, racism and mistreatment of Aboriginal and Torres Strait Islander people, including forced removal of people from country. The theme here is the need for connection for an Aboriginal Torres Strait Islander person. Connection not only to people, but also to every facet of country and how they are integral to and inseparable from that existence. Connection is central to a person's identity, sense of self and purposeful life. Much distrust has come from the intentional and incidental breaking of that connection by non-Indigenous people, services and government. We wish to emphasise the role of the elder in Aboriginal and Torres Strait Islander society. Whilst the recent evidence of Ms Curnow really does speak for itself, we commend the observations in paragraph 31 of her statement, where she said that elders and old people have developed over their lives deep connections throughout their immediate extended families and communities. They may have amassed a large amount of social and cultural capital. The methods and values and beliefs for accumulating this social and cultural capital are embedded within all aspects of Aboriginal and Torres Strait Islander collectivist cultural practices handed down from former generations. And it is not necessarily a purposeful act that is motivated by the need for insurance in times of need. From birth to death, Aboriginal and Torres Strait Islander social norms reinforce values and beliefs to look after each other and connect with each other, from sharing food, stories, experiences, assets, and solving collective public problems. Finally, turning to a different topic, and consistently with the evidence the Commission has received in earlier hearings, the My Aged Care interface would seem to be woefully inadequate from the perspective of those who assist Aboriginal and Torres Strait Islander people in remote and very remote areas. On this, you need go no further than the evidence yesterday of Ms Crawford, when she described it as dreadful and described it further in these terms. It relies on people having the telephone, internet, being at a fixed address and speaking English, and being cognitively intact and not being too frail to not have the energy to deal with the system. So if a referral is made to My Aged Care, then the My Aged Care people will try to contact the client. If it's not made by a clinician, then they will try and contact the client by telephone. On the My Aged Care system, when you're doing referrals, they have a ticker box that you can say the person speaks an Aboriginal language, but there's no place to specify which Aboriginal language it is, and they don't use interpreters, not even Creole interpreters, when they telephone back to clients. Commissioners, before we close, I repeat the invitation made in my opening for people to come to the community forum that will be held here this afternoon at 2 o'clock. We remain keen to hear from all of those who wish to share their experience of these matters. The forum commences at 2 p.m. I wish to close with the remarks of Faye Dean when she said on Monday morning, "Elders are our future, our culture, and that's who we learn of, our elders." Thank you, Commissioners.
Yes, thank you, Mr Bolster. The Commission is indebted to Council, instructing solicitors and support staff for all the work that's been done to establish these 3 days of hearings in Broome. We're particularly conscious of the work that has been done to establish communications and record the proceedings. It's involved an enormous logistic task of moving equipment from one part of the country to another, and we're very mindful of the hard work that has been done by many people to ensure that these proceedings could proceed smoothly as they have done. We endorse what has just been said by Mr Bolster about the importance of the opportunity provided this afternoon for the community to express views informally to the Commission, and we encourage all those who may be interested in making their views known to the Commission to take this opportunity, which will shortly arise. The Commission will resume formal hearings in Perth next Monday, and will adjourn until 9:30 a.m. on the 24th of June.